Bom, gente, tudo bom? Bom dia a todos. Mais uma vez aqui junto com a gente no SBRH Update. Hoje, o último encontro que nós temos todos juntos pela Sociedade Brasileira de Reprodução Humana. Agradeço muito a parceria de todos ao longo de todo esse ano, meio complicado por causa da pandemia, mas realmente isso trouxe outras possibilidades de contato, trouxe uma vasta possibilidade justamente de acesso a conteúdos, a profissionais do mundo inteiro, uma proximidade com esses profissionais, a possibilidade de fazer perguntas em um webinar. Então, sempre na vida tem o seu lado ruim e seu lado bom. Então, mas é claro que a gente espera que o ano que vem a gente consiga fazer todos esses encontros, todo mundo pertinho um do outro, que é o nosso grande objetivo. Tá? Então, realmente, em nome da Sociedade Brasileira de Reprodução Humana, eu agradeço muito essa parceria e esse convívio ao longo do ano. E claro que no ano que vem vai ter mais, sem dúvida nenhuma. Bom, hoje a gente está com uma pessoa extremamente especial, o professor Alberto Vaiarelli, tá? Ele tem bolsa de pesquisa na Yale Fertility Center, uma bolsa também na Medicina Reprodutiva na Universidade de Bruxelas, tá? Ele é doutor em ciência endocrinológica e metabólica experimental na Universidade de Messina, tá? Ele tem mestrado de segundo nível em Ciências da Reprodução e Técnica de Reprodução Assistida na Universidade de Urbino, tá? Ele é mestre nível 2 em Andrologia e Medicina Reprodutiva na Universidade de Pádua. Além disso, entre outros títulos, ele é membro do Conselho Editorial da Revista Científica do Jornal de Reprodução Assistida e Genética, tá? E hoje vai conversar com a gente sobre um assunto extremamente atual, que é justamente o DuoStim na obtenção de respostas melhores em pobre respondedora. Bom, professor Alberto, thank you very much for being with us today in the name of the Brazilian Society. Okay, so we are very anxious to hear you about this important tema about DuoStim. Thank you very much, Professor.
So thank you very much for the invitation. All the time is very my pleasure to participate in this meeting. I love the Brazilian colleagues. I had the opportunity to meet many colleagues, and so thank you very much for this opportunity. Can you see my screen?
1 minute. Yes. Okay.
And so thanks again for this opportunity, because I had the opportunity again to discuss about these important strategies that there is the DuoStim protocol. I will try in my presentation to make an overview regarding the management of the poor responder and the possible application of these strategies. So this is my disclosure. So of course, the point is that the management of the infertility patients is changing over the time, because of course the opportunity to make a blastocyst culture, the opportunity to make the aneuploid testing, the vitrification, and the knowledge of the dynamism of the folliculogenesis have profoundly changed the approach when we manage infertility patients, and in particular when we manage poor responder patients or poor prognosis patients in general. The point is that in our clinic, for example, the mean age is 39-40, and so the majority of the patients that we treat are patients with advanced maternal age, and so with a physiological reduction of the fertility potential. And also when we manage patients in advanced maternal age, of course, we have to take in consideration the risk. And so in our goal, when we manage infertility patients, will be important to obtain a a baby. Of course, this is the only measure of the success. But of course, we have to take in consideration other important aspect, the time to pregnancy, try to reduce the burden for our patients, try to reduce the cancellation rate, of course, try to minimize the risk for the pregnancy. Of course, the first risk after the IVF treatment is the multiple pregnancy. This is a very important point. We have to try to reduce the risk, and so we have to try to push ourselves to transfer all the time one embryo. This is everybody know this concept, but I think it's important to remember because we have to try to transfer this concept with the patients when we talk with the patients, and so we have to try to optimize the response, and it's important when we stimulate patients, and if we want to optimize the response, we need to know the ovarian reserve. But when we talk about the ovarian reserve, we are talking about the quantitative. And but another important concept is the quality, and we will see that the only parameters to correlate qualitative is the age of the woman. So the prediction of the ovarian response it's mandatory when we have a patient in front of us, just for the doctors, because the doctors will personalize the treatment for every single patient according with the ovarian reserve. Ovarian reserve means biological age of the woman, but also for the patients, because we can clearly explain to the patients the realistic chance according with the ovarian reserve when we manage infertility patients. So this picture, I think it's very clear. Reduction of quantitative, this is a physiological, a reduction of qualitative. And what does mean qualitative? Because in many cases we talk about the quality of the oocyte, quality of the embryo, but if you want to codify, if you want to understand the realistic words, competence, the oocyte competence means blastulation rate, and we have a negative trend when we increase the age of the patients. After 40, we have a low blastulation rate, but also everybody knows that there is a high increase in terms of the aneuploidy rate when we manage infertility patients. And so these information are very important to discuss with the patients in order to understand the realistic chance when we make an IVF treatment. And this is just a picture from the Italian picture. We can see this is the Italian register, and we can see that the number of the patients more than 40 is growing over the time. And the patients, the young patients, unfortunately, we don't have a young patient to treat. And so this is the flow chart when we regarding all the steps that we have during the IVF treatment. And the control of the ovarian stimulation is a crucial point. It's very important to select the right protocol, and which we can discuss if there is a right protocol. We can discuss about which is the best gonadotropin, or which gonadotropin can use to maximize the chance for our patients. We can discuss about the starting dose, and everybody knows that we decide the starting dose according with the patient's profile. But the point is that when we make the ovarian stimulation, we have to take in consideration efficacy, safety, cost, and the patient acceptability. Because our goal is to try to increase the number of the oocyte and try to have a good quality of the oocyte. It's just this slide, I think, is just to underline that I don't believe that modify the dose of the gonadotropin during the stimulation can make a difference. This is a national survey, a national Delphi consensus that we make the last year in Italy, and the majority of the doctors are agree that there is no reason to modify the gonadotropin dose when the doctors are able to make a correct tailor regarding the ovarian, the prediction, the ovarian response. And in fact, if you read the Escher guidelines, the Escher guidelines does not recommend the modification of the dose during the control of the ovarian stimulation. And so the point is that what we can do in different patients, in difficult patients. Difficult patients means patients with a poor ovarian response, so with very low ovarian response, very low ovarian reserve markers, and patients with advanced maternal age. Of course, there is no story. The number of the oocyte is a very key point. If we increase the number, you can increase the chance. However, we are not able to create ex novo follicles with the gonadotropin. And so the point is that maximize for every single patient the potential that we have. Which gonadotropin we can use? We can open a big discussion. We can organize a lot of meeting, a lot of congress. I will try to put some evidence. The point is that if you look in different trial, in a randomized control trial, agonist or antagonist protocol, when you use the recombinant, you have better result in terms of number of the oocyte. Compare with the urinary gonadotropin, and these conclusions are confirmed in several meta-analyses and in several reviews. Of course, in this type of the paper, you put inside the different group of the patients, but the results are concordant that when we use the recombinant gonadotropin, you can make some difference in terms of number of the oocyte. But this is not the only aspect. Also, the quantitative of the gonadotropin is an interesting topic, because in many countries, the patients pay for the gonadotropin. In Italy, the government pay for the gonadotropin, for example. But anyway, when you use the recombinant, seems to be cost effective, because the total amount of the gonadotropin compared with the urinary approach is cost effective. I divide some three different groups. In this different group, I think we need to be attention when we stimulate this woman. Patients with suboptimal response is the first group of the patients. And in this group of the patients, suboptimal response, according with the Poseidon definition, are patients with a normal ovarian reserve markers, but at the end of the stimulation, you have a suboptimal response, so less than 7 and 9 oocyte. But of course, the point is that 7 oocyte seems to be good, but depend which is the ovarian reserve, because which is the approach that can I use to maximize the ovarian response, to optimize the number of the oocyte when we compare this number with the antral follicle count. Of course, the application of some specific gonadotropin, such as the LH recombinant, so the LH activity can make an important difference in terms of number of the oocyte, but also in terms of clinical pregnancy when we transfer in the fresh embryo transfer. This data was also confirmed in some other data coming from the real world data. What about the advanced maternal age? Of course, we cannot compensate the damage that we have in oocyte in the oocyte with age, and so I don't have any strategies to go back with the time with the treatment. But of course, according with the literature, again, when you use the recombinant gonadotropin, and so FSH recombinant plus the LH recombinant, we can have some benefit in terms of clinical outcome and in terms of number of the oocyte. This is, for example, one of the randomized control trial, according and taking consideration the Bologna criteria, so very poor prognosis patients, And we can see that when we have patients with more than 40 and with a very few oocytes, when you use the recombinant gonadotropin plus LH recombinant, we can make some difference in terms of live birth rate compared with a group without LH activity. And also other data coming from a huge number of the cycle confirm that this approach, FSH recombinant plus LH recombinant, can be an efficiency strategy in terms of increase the cumulative live birth rate. What about the quantitative? Because this is an old discussion, but always we have the same problem. Some philosophy, some trials support that when you use less gonadotropin, you can increase the qualitative of the oocyte, because we can have a natural selection of the oocytes that you are able to retrieve. But this is apparently is not true, because we can see in very good trial that when in different group of the patients, that according with the total dose of the gonadotropin and total number of the eggs, there is no difference in terms of the quality. In terms of the quality means in this case the chromosomal status of the embryo, because of course we said before that the only characteristic that we have to take in consideration when we talk about the competence is the blastulation rate and then the chromosomal status of the embryo. We can see that in this paper there is no any different according with the number of the gonadotropin when we correlate the total dose of the gonadotropin and qualitative of the embryo. The same result are confirmed in the donor group. In fact, this paper confirmed that the aneuploidy rate did not increase with the ovarian response at the total dose of the gonadotropin in donor population. And so what we know that there is no reason to increase more than 300 units of the FSH during the stimulation, and where you can use wherever you want, but we cannot create follicle ex novo. And so now there is our topic. Our topic is what we can do in patients like that with a 2 antral follicle count, with a very few antral follicle count. Of course, the first problem was the definition, but unfortunately in 2011, the Bologna criteria was the most common definition regarding the patients with low ovarian reserve markers. But if you look the data, when we have Bologna patients in front of you, patients with less than 3 oocytes, more than 40 years old, of course, the live birth is around 6-7%. And this information, I think, must be clear with the patients. I can use whatever you want, which you can select any protocol, any gonadotropin, but the results are around 60% in terms of live birth per intention to treat. And so in the many cases we discuss and say, okay, but I make a personalization of the treatment, and so I can combine different gonadotropin, I can use different dose, I can start in different days, but what does mean personalization of the therapy? So I think that today the personalization of the therapy means try to increase the number of the oocyte related to the antral follicle count, try to transfer only embryo with high implantation potential, and so try to segment the cycle in some specific case, and so make the simulation, and then one cycle later do make the transfer, or using unconventional stimulation. Unconventional stimulation. Another definition now, I think, is more accurate. This is the Poseidon definition. The importance of this criteria was that we can distinguish young patients and older patients, and I think this is a very important point, because of course when we manage poor responder patients, but young patients, we have to take in consideration the risk of the aneuploidy rate is totally different when we have a patient less than 35 or more than 40. And also another important point is the response, because in group 2 and group 4, of course, you can have patients in group, we can have patients with a good ovarian reserve markers, but at the end of the stimulation, we can have a low number of the eggs. I think this is important to make this ratio between the antral follicle count and between number of the oocyte. Because now what we have to try to think, what we have to try to discuss with the patients is that, okay, I will stimulate you, but which is the ideal number of the oocyte to obtain at least one embryo with a high implantation potential? Because my goal is just not to collect oocyte, but it's just to collect the right number of the oocyte according with the specific patient's characteristic. And this picture is just to summarize this concept in young patients, of course, according with the low rate of the aneuploid rate, we can have a few eggs, and maybe few eggs are enough to obtain one good embryo. But of course, in a patient with a 42 years old, we need a huge number of the eggs. And so the point is what we can do. The dynamic process of the follicular development has introduced a new model in describe the folliculogenesis. I think this information is changing our approach when we manage IVF patients and when we stimulate IVF patients, because of course what we know today is that maybe we have a continuous recruitment of the waves, so we have many waves between one cycle and another cycle, or we have 2 or 3 waves according with the duration of the stimulation. However, the problem is that we don't know anything regarding the mechanism that we have behind these waves. But what we know today is that you can start conventional with the gonadotropin. This is in day 2 and day 3, what we do in our clinical practice, or we can start in the luteal phase, or we can start in the middle of the cycle. However, we know this information because when we make a random start in fertility preservation setting, we start without we start randomly without any specific days. And so this is possible. Why? Because we have different waves between between 2 menstrual cycles. So, of course, the improvement in the lab, thanks to the vitrification, has been a game changer in assisted reproductive technology. And this is the reason why today we are talking about the unconventional stimulation. Because, of course, in this particularly protocol, we have a asynchronism between the endometrial and between the ovary. And so, of course, if we don't have an efficiency cryopreservation program, if you are not able to freeze our oocyte or our embryo, we cannot stimulate women with unconventional stimulation. But of course, when we make unconventional stimulation, we have many topics that we have to discuss. The first question is, we can use this approach in outside the fertility preservation setting. We have a competence oocyte in terms of fertilization and blastulation. The euploidy rate of the embryo is comparable with the embryo coming from conventional stimulation. The progesterone level can have some effect, and also when we transfer euploid embryo coming from luteal phase, from an ovulatory ways, we have the same result in terms of the live birth. The first application, everybody knows that the double stimulation was the Shanghai protocol. Just everybody know this protocol, but just I think that we need to take attention regarding the protocol. So this is a modified natural cycle, or this is a mild stimulation. I don't know. We can use different definition, but anyway, we use Clomid plus low HMG dose every day. But in the second stimulation, the stimulation was totally different. So the protocol was 225 units of the HMG. Of course, the importance of this study was that for the first time, they demonstrated that you can use an unconventional stimulation in poor responder patient to increase the number of the oocyte in a short time frame. The problem, I think, regarding the mild stimulation, or when we use low dose of the stimulation comparable with a conventional, I think it's very clear explained in this paper. So in this paper, we have two different groups: modified natural cycle versus conventional stimulation. It's very clear for Bologna patients, so patients with advanced maternal age and poor ovarian reserve markers. It's very clear that when you use the modified natural cycle, we reduce the number of the oocyte, we reduce the number of the metaphase 2, we increase the cancellation rate, we decrease the patients with at least top quality embryo, we reduce the number of the potential embryo cryopreserve, and we reduce the pregnancy outcome. And so the problem is that in patients that are able to collect more than 2 oocytes, there is no reason to use a mild stimulation. If we are able to collect 3 oocytes can make a difference in terms of just 1 oocyte with a mild stimulation. And of course, the ESHRE guidelines are in line with this concept, because in poor responder, the natural cycle seems to be not recommended. In our opinion, we believe that if you are the possibility to stimulate a woman, you have to do this, because of course you can make a difference. Just 1 oocyte, 2 oocyte in this specific patient's population can make a huge difference. This is our protocol. Everybody knows this protocol. So we start with estradiol priming. We use in poor responder patients this approach to synchronize the cohort of the follicles, because of course in antagonist cycle we can have asynchronism, and when we have a few follicles, this asynchronism can be different, and so our goal is to try to have all follicles in the same line. We use 300 dose of the FSH recombinant. This is the maximal dose that we use, and we use 150 of the recombinant LH. We use flexible antagonist protocol, GnRH agonist for the trigger. This is we can discuss, but we know that when we use the agonist trigger, we reduce the time of the corporal lutea, and so we do the pickup, and so after 5 days is enough time to reduce the level of the hormone, and then we restart automatically with the same stimulation, with the same identical protocol. So the proof of concept regarding this protocol was published in 2016, 4 years ago. And then every year, so we collected data regarding this application. We published in 2018 this paper. This paper was important because we demonstrated that when you use conventional stimulation, follicular phase stimulation, and luteal phase stimulation, we have the same fertilization rate, the same blastulation rate, and the same euploid rate. But of course, we can see that the correlation between the first and the second stimulation is only 50%. So there is a huge difference between the first and the second stimulation in terms of number of the oocyte. And then we demonstrated that when you use in poor prognosis patient this approach, we can increase for each single patient the possibility to obtain at least one euploid blastocyst from 42% to 65%. And so this is just to underline the important contribution of the luteal phase when you do a double stimulation, when you make 2 stimulations consecutive in terms of how many cycles at least we try to obtain one haploid embryo, because our goal, as I said before, is to obtain one embryo with the implant, with the high chance to implant. This year we published a specific paper in a specific group of the patients, Bologna patients, and we tested our protocol, and so we make a retrospective control with historical control when we didn't have the opportunity to make a double stimulation in the past. So the conclusion of this important paper was that when you make one stimulation, you only conventional, you have 7% of the live birth per cycle. But if you do a double stimulation, you can have a double possibility to have a baby. And so with the double stimulation in Bologna patients, you have 15% to have a baby when we make a double stimulation, compared with 7% when you use a conventional approach. But this concept is important. Why? This was our data between 2013 and 2014. So we can see the number of the patients, 178 Bologna patients, Bologna poor responder patients, and the live birth rate was 60%. And so this number is stable. But what I want to discuss with you is the dropout rate that we have in this specific group of the patients. So when we have patients with more than 40, with low ovarian reserve markers, after the first IVF treatment, we have 60% the dropout rate. Only 35% of the patients came back to us for the second IVF treatment. And here we can see the distribution, where many patients coming after 1 month, but look, there is another group of the patients that came to us after 6 months. And we know that in this group of the patients, the time is very crucial. It's not only for the dropout for us, but it's crucial because, of course, the age increase, the risk of the aneuploid increase, and of course, the situation regarding in terms of number of the oocyte will not improve. This is the reason why the application of the double stimulation in Bologna patients, it's important, because we cancel the dropout, because we explain that we have to make 2 stimulation for 1 IVF treatment, and also we reduce the time between the first pickup and between the second pickup. But in our retrospective analysis, there is no difference when we do a double stimulation compared to conventional stimulation in terms of live birth. This is another important point, because thanks to the experience of the double stimulation, we understood that there is a very huge variability in terms of number of the oocyte and number of the embryo when we make the same stimulation in 2 different time of the menstrual cycle, and only 15% of the cycle we have the same number. Only 31% of the patients has the same number of the embryo. So what I'm trying to say is that there is a very huge variability, not only between one cycle and another cycle, but also intracycle variability. So the reason is that we don't know why. Of course, maybe we can have some positive effect of the previous stimulation in the second stimulation. We can have a better synchronization of the cord of the follicles in the new waves. Of course, so the high level of the hormone can stimulate the proliferation of the FSH receptor in the granular cells in the new waves. There is something maybe that can make an improvement in terms of ovarian microenvironment. We can have an increase in the androgen factors. Also, we can have a positive effect in terms of the flare-up when you use the GnRH agonist for the trigger. So anyway, this is just the speculation. All these hypotheses must be confirmed. But this was the last paper that we published this year, Human Reproduction, and this was the last question. Okay, I have more oocyte when we stimulate women in the luteal phase. I can increase the total amount of the eggs. I can increase the total amount of the embryo. We have the same blastulation rate. We have the same aneuploidy rate. But when I have a euploid blastocyst come from luteal phase, from an ovulatory waves, we have the same efficacy in terms of live birth. So this is the number of the double stimulation that we did up to now. And this is just another discussion that I can make with you after. Anyway, a huge number of the double stimulation. And what we can see is that when we transfer euploid embryo coming from an ovulatory waves, we have the same live birth, and we didn't find any difference in terms of obstetrical and neonatal outcome. This strategy also is important in the PGT-M and the PGT-SR, so in patients with monogenic disease or with a translocation, because in these patients, of course, the strategies to improve the number of the embryo to be biopsied can make an important benefit. Now, many meta-analysis is coming. So in this meta-analysis, this was the last. So the DuoStim is a strategy in order to use in poor responder patients to increase the number of the oocyte, the number of the embryo, and also seems to be no different in terms of aneuploidy rate when you use unconventional stimulation. Also, we confirmed this conclusion, and we make a review, an interesting review, because we take in consideration different protocol in terms of the DuoStim with different gonadotropin in different setting, and the conclusion of our review was that this approach is safe and of course is reproducible. And this is the most important part of the work. We have to use something that we can reply in different setting, maybe with different protocol. Unfortunately, up to now, the indication of the ESHRE guidelines is that we can use a double stimulation only in the context of clinical research. However, we wrote a letter in March because we believe that the data is coming, and today we have a good evidence. Of course, we need to improve this evidence, but we can use this approach in a specific subgroup of the patients, such as poor prognosis patients. And so this is just one of my conclusion. I think when we have a patient in front of us, when we decide which is the protocol, we have to take in consideration the age, we have to take in consideration the ovarian reserve, we have to take in consideration the number of the IVF treatment, and when we decide the strategies, we have to put all this information in the cost-effective analysis: efficacy, safety, cost, patient's acceptability. Because of course, the patient's opinion is a very important point, and we have to decide together with a couple regarding which is the best strategies to have a realistic chance to obtain a baby. And so, of course, today the multiple follicular waves is something that we know, and so we need to understand something more. But up to now, this is the opportunity to collect oocyte from an ovulatory waves is a good strategy. When we obtain oocyte, when we have embryo, seems this embryo and this oocyte are comparable with a conventional approach. And of course, the luteal phase stimulation in the DuoStim protocol can make an important contribution in terms of number of the oocyte, number of the embryo, in terms to reduce the time, in terms to reduce the dropout rate for our patients. I think the most important benefit of the DuoStim is the dropout rate. This is maybe an important point for our patients and for our result. Of course, we need a multi-center prospective randomized trial to confirm all this evidence. So thank you very much for your attention.
So, Alberto, thank you very much for your excellent presentation. And we have some questions here in the chat. And but I have one question. Which is your endometrial preparation after DuoStim when you are going to transfer embryos? This is the first question.
Okay, so thanks. We are working on this approach. So up to now, if you look the evidence, when you make a frozen embryo transfer, you can use pure natural cycle, pure natural preparation. You can use modified natural cycle, or you can use artificial cycle. If you look the data, there is no any difference. And we can confirm, we are working, I told you regarding this paper, we don't have any different according with the type of the preparation. In our setting, we use only modified natural cycle and artificial. We don't use pure LH, pure preparation with the natural LH source because it's very complicated for us. Also because we have many patients coming from different parts of the Italy. But if you look the data, there is no any different. And according with our data, we didn't find any different if you have embryo from luteal or for conventional stimulation.
Okay, Professor Alberto, another question. Okay, you're going to prepare the endometrium for the embryo transfer, okay? Why not, instead of only doing an endometrial preparation, doing a third stimulation protocol, and then you have another oocyte pickup, and then in this cycle you do the transfer. So you have the embryo, the vitrified embryos of the two cycles, the DuoStim cycle, and then another cycle that you have fresh oocytes, fresh embryos, and then you can even think about transferring in the same cycle.
Yes, okay.
It's a good idea, not a good idea?
No. It's a good idea. Some paper is what's been published regarding the DuoStim, for example. I don't remember the name. So the point is that which is your goal? Because if you want to accumulate embryo, of course you can make quadristim. You can make many embryo. For example, in our setting, is forbidden to collect embryo. And so I cannot make many pickup to have many embryo in the freeze. So my strategies of the DuoStim is to try to, in 1 month, to increase the number, to have many embryo, to have more embryo to analyze for the pre-implantation genetic testing. Because the point is that when you do a DuoStim, you combine. Do you combine the pre-implantation genetic testing? Because otherwise, I think these strategies is just a good idea to reduce the dropout. And of course, this is a good idea. But in our setting, our approach at the beginning was, okay, I want to make the analysis because in these patients has the indication. The first indication is the advanced maternal age, okay? So at 40, we have 60%, around 60% of the aneuploid rate. And so if I have one embryo after conventional, so it's very clear, we have very low chance to obtain one aneuploid embryo. If you have 2 embryo, of course, you have more, or if you have 3 embryo. So the point is that the analysis, I think, but if you select patients, for example, advanced maternal age plus abnormal karyotype, for example, plus monogenic disease, somebody can happen. We have a case report regarding these particular couples. Of course, in these patients, if you have many embryo, you have more chance to obtain just one embryo with a good chance. But what I'm trying to say is that my goal is not to collect oocyte or collect embryo. If I have one haploid embryo, maybe this is my preliminary goal.
Okay. And if you have a poor responder with low age, do you think that's worth to do the triple STIM, or even in this case that we're not going to do PGTA, we're going just transfer perhaps the blastocyst, and then do you think in this case it's worth to do the third stimulation cycle or no?
So I think the point is that which is the goal of the couple, to have one baby or to have a family? Because I think we have to switch our goal, because many couples come to us to have a family. A family means one baby, but maybe means two babies, three babies. Of course, if I have young patients and if I have one blastocyst, of course, this blastocyst has a potential. Of course, if I can freeze embryo, maybe for this couple, I can increase the possibility to have a second baby. And so I think it can be a strategist. The point, can you hear me?
Yes.
And so the point is that in Italy I cannot make embryo banking, for example, and so I don't believe that this strategy is applicable in my setting. But anyway, you can use according with the couple, according with the legislation. Why not? This is, but of course, is the same, because if you, in terms of our experience was, if you make two stimulation or DuoStim, up to now we didn't find different. Of course, if you make two stimulation after 2 years, this can make a difference.
Okay, Professor, we have another question here in the chat. What do you think about double trigger on second phase of DuoStim protocol?
Sorry, can you repeat, please? Sorry.
What do you think about double trigger on second phase of DuoStim protocol?
So I think that there is a scientific discussion about the double trigger. I think the double trigger is recommended in a specific situation. For example, very low level of the LH, very low level of the LH the day of the trigger. So, or in specific patients with a suboptimal response. So, for example, we can have patients with the day of the trigger 6 follicles, big follicles, but trigger pickup, and then you collect 2 eggs. Why? So in these patients, we can use a double trigger, but the indication of the double trigger is in poor responder. Automatically, I think we don't have enough data. Maybe you can change the trigger in the second stimulation. Why not? At the beginning of our protocol was to compare 2 identical protocols. Of course, if you change the trigger, you can have different, I don't think. Because if you use a recombinant urinary or agonist, maybe we don't have any trigger. There is one paper, is a retrospective paper, that when you use recombinant ACG or agonist, you can have better result in terms of qualitative of the embryo compared with the urinary ACG. This is just one paper, but I think there is no indication to make in all DuoStim patients a double trigger, or when you have a suboptimal response.
Okay, Professor, thank you. And another question here on the chat is that if when you do DuoStim in the first cycle, you freeze oocytes, or you already freeze embryos?
If you make the analysis, we freeze embryo. If we don't make the analysis in young patients, for example, we freeze oocyte, because in Italy we cannot make embryo banking. This is the reason. And so in a DuoStim protocol, we make them, we biopsy the embryo, because also another important point is that you can have patients with very not unexpected response. So, for example, 4 oocyte, 3 blastocysts, you can have. And so the point is that we are thinking about this concept. There is a specific cutoff level in terms of number of the embryos to make a second stimulation, or to say, okay, can be enough. Because of course the cost effective we have to put in the balance. And so if I have a young patient, for example, with a 3 blastocyst, why I can stop the treatment? We decide the second stimulation in many cases according with the blastocyst that we have.
Okay.
I think this is the personalization. Personalization means to modulate your approach in itinerary during the treatment.
I think the individualization of the protocol is always our goal, I think.
Because in the past, or for some specific philosophy, individualization means modulate the dose. But this is nothing, I think, if we take in consideration the individualization. Individualization is something more.
Professor Vaiarelli, another question. You use only 0.1 of agonist in the, to trigger, not 0.2.
So in the past we used buserelin.
Okay.
50 units, international unit of 0.5. Now we are using you can use I don't remember I remember the commercial name. I use the 0.2 I use. I'm sorry. 0.2, but not buserelin. Not buserelin. I use because we have 3 different moleculars for the agonist. We have buserelin. We have I have a lapsus, but we use 0.2.
Okay. So, Professor, we have all the questions answered. So we are very, very thank you for your participation with us, and we have also to thanks for Merck that's help us to do this webinar today. Então, agradecer a Merck pelo apoio nesse webinar. Muito obrigada. Thank you, Professor Vaiarelli. Muito obrigada a todos online. Esse conteúdo vai ficar no YouTube para todos que quiserem ver posteriormente. So, Professor, thank you. Have a good Christmas, Happy New Year, and we hope we see together next year here in Brazil, not online.
Thank you very much for this invitation again. Thanks, and Happy New Year and Merry Christmas.
Okay, thank you, sir.
Bye.
Bye.
Bye.